ones. So Dr. Nwabuobi, thank you so much for joining me. Again, you're a maternal fetal medicine specialist. Tell everyone where you're located and where they can find you on social media.
Thank you very much. Hello, everyone. Dr. Nwabuobi here, maternal fetal medicine doc in Columbus, Ohio. I am with the Mount Carmel Health System. And my IG handle is at Perinatal Care MD. So feel very free to join, share, like, subscribe, all that good stuff. And yeah, I appreciate you guys. And thanks for the opportunity as always. Really appreciate it.
Well, thank you. So we're going to start off. I'm just going to throw out some stats. And we briefly touched on these in our last discussion regarding maternal mortality. Over 700 women die each year in this country, the United States, from problems related to pregnancy and delivery complications. Black, American Indian, and Alaska Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. This disparity increases with age. And the CDC and other centers, state and local levels, all have ways to track maternal deaths within their within each individual state and then nationally. And we're going to talk about 2 of those ways: the MMRC, which is a maternal mortality review committee, and then also the perinatal pregnancy and maternal surveillance system. We're going to discuss the stats for those 2. Moving along, 2/3 of pregnancy-related deaths have been determined to be preventable. And then finally, as many as 50,000 women experience severe, unexpected health problems related to pregnancy that may have long-term consequences. So Dr. Nwabuobi, talk a little bit about what happens in pregnancy and what predisposes some of these individuals to increased risk of morbidity and mortality. What is it that's going on that could make some individuals more susceptible to that?
Thank you. So, when a woman becomes pregnant, the body has to make certain changes that are considered physiologic so that this body is able to accommodate pregnancy as a whole. And because of some of these changes that a woman goes through, physiologically, things appear different. But the very important part of this whole process is for a woman to also understand that despite the fact that some of these physiologic changes are normal, that there are a certain spectrum of what is considered normal where you suddenly start steering away from that and moving towards signs that might actually point you towards things not being normal anymore. So then it now comes down to, are you able to actually realize that what's happening to you is no more normal and has veered away towards what's abnormal and what can be concerning? And also just being able to have a team around you that can recognize that on time and also lead you to the right group of people to make an accurate diagnosis and management. So it becomes a multifaceted issue. And in addition to that, the last conversation we had was about the whole CDC Hear Her campaign. Women knowing that things are just different, they might not be able to know the right medical terminology to explain exactly what's going on, but then being able to say, listen, I just do not feel well or feel myself, and having the right people to listen to them, hear them out, and being able to intervene appropriately.
Yeah, and then, one thing that's important as well is, and I talk about this a lot, is especially with more and more individuals becoming pregnant later in life and carrying with them pre-existing medical conditions. Because as we age, we get high blood pressure, we get diabetes, we might have developed some autoimmune diseases, and then adding pregnancy on top of that, if those conditions are not optimally controlled, and then you add pregnancy on top of that, that could put you behind the 8 ball, if you will. And playing catch up in pregnancy is not ideal. So that is a contributing factor as well, is if there are pre-existing medical conditions, if the patient does start out in the obese or above category, those types of things are contributory too. It's not blaming the patient, but what it's telling you is, if you know that you have these things going on, seeking care early, making sure, especially if you have what we call comorbid conditions like uncontrolled diabetes and hypertension, that you ask for a referral to somebody like myself and Dr. Nwabuobi to get that extra set of eyes and assessment on you. And we're going to talk about more about that later, is how to advocate for yourself. I think myself and Dr. Nwabuobi both agree that part of the education that we do here on social media is teaching people and giving them the tools to advocate for themselves. Because unfortunately, it's come down to that. And we mentioned all that before, until things change within the system level, and we'll talk about that as well. The patients, we need to make sure that they understand that they can advocate for themselves. Would you agree with that?
Absolutely, 100%.
Yeah.
Yes.
Yeah.
And what I wanted to just throw in real quick was, with the whole us being maternal fetal medicine specialists, we tend to
Yes.
see people coming to us when they are already pregnant.
Yes.
And a lot of conversations we have, in our mind, we're saying, oh, only if I saw you before I became pregnant. So the preconception period is a very, very important period.
So while we're on that topic, you can ask, or you can get a maternal fetal medicine, what's called a preconception consult.
Yes.
If you've had recurrent pregnancy loss, if you've had a stillbirth, if you've had a traumatic birth, if you have pre-existing medical conditions, you can see one of us before you even get pregnant for planning. I love it. I know you probably do too.
Same here.
If somebody is proactive and they come to us and say, listen, this is my history. What can I do now in preparation? And then what are we going to do differently when I do become pregnant? That makes things so much easier. And then for the obstetricians that are listening, and I see this, and I'm in Texas, so but I'm sure it happens everywhere, but we have a lot of areas where they don't have access to MFMs, or for whatever reason, sometimes the obstetricians will hold on to the patient a little bit longer than I prefer, and I'm just like, just send them my way, send them to me. I promise we're not in the business of poaching patients is what we're concerned about. That's not it. That's not it. The provider, the OB/GYN will tell us, yes, I just want to consult, yes, I want you to co-manage, or I want you to take over care. Yes. Those are the three options. We're completely okay with that. Yes. So don't be afraid to let us know which one of those three that you want. So, and as a patient as well, you can ask for a consult. So has that been your experience too?
Yeah, that's been my experience. And I like the last thing you said about the general obstetrician understanding the fact that we are part of the team.
Yes.
That we are not here to take the patient away from you. Just let us know exactly what you want, and that's what we plan to do, and have your patient right back to you. Absolutely.
Exactly. So, we're not wanting to take anybody away from their patient. We just want to make sure that the care is excellent. Absolutely. Okay. So we're going to talk a little bit about the CDC presented some data, and I had this to go over the last time, but we didn't get to it, where they got data from 14 maternal mortality review committees from 2008 to 2017. So explain to the listeners what a maternal mortality review committee is.
Okay, so Maternal Mortality Review Committee, it's a multidisciplinary team of experts that they convene on a state or local level to basically do a comprehensive review of deaths that occurred in women during or within 1 year after pregnancy to determine exactly what must have caused a death and try to come up with recommendations to prevent similar situations occurring again. And they are able to do this by actually reviewing both clinical and non-clinical information. And you are talking about things from medical to social service records. Yeah. Things like housing, access to food, etc., that might have played a role into the death occurring, no matter what it is. So it's a very, very important committee, and the data that's coming out of this committee has been helping us do a lot of great things recently.
Right, but the unfortunate thing is not every state has one.
Yes.
Not every state has them. That's one of the things, and we're going to talk about at the end of this, the Kira Johnson Act, and I'll explain to you what that is and how you can help us promote that and advocate for that. But that's one of the things that they're looking for in the Kira Johnson Act is to get MMRCs in every state. I know we have one in Texas, and I actually just applied to be on it, and I'm keeping my fingers crossed that I'll get the position. That's something that I'm very interested in, but that's where they have people from different areas of obstetrical care that are on these committees to help review at a nursing level, at the physician level, and different levels about the care the patient received and what happened leading up to their death. So those review committees are extremely important. And touch a little bit, one of the things the maternal mortality review committees do is they differentiate between a pregnancy-related and a pregnancy-associated death. What's the difference between those two?
Okay, so pregnancy-associated death will be a death of a woman during pregnancy or within 1 year of the end of the pregnancy from a cause that is not related to pregnancy. So I think about this like, for example, maternal homicide or suicide, right? You cannot necessarily say that it's directly related to the fact that the person is pregnant. However, it happened around the time of pregnancy or within 1 year after. So that would be pregnancy-associated. Then pregnancy-related. So now this would be a death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication. Now, you can also think of it as chain of events that were initiated by pregnancy, or if they had some kind of underlying condition that pregnancy exacerbated or aggravated. So that would also be included. Now, to give an example, I'll say something like, let's say you have a patient who had chronic kidney disease, right? They come into the pregnancy, now they become pregnant, and just the physiology of pregnancy just overwhelms the kidneys. And all of a sudden, now you have this mom who might have been a stage 1, stage 2, all of a sudden suddenly progressing to stage 3, stage 4. So in that case, it will be pregnancy related. And then we'll talk about, other things, but that's kind of like a basis of the definition.
Yeah, and then, so that's important too to understand, because you'll find out, and we'll go through these two particular, the MMRC and the PMSS, but there's not really standardization of how the data is interpreted, so that can be problematic too when we're trying to look at it globally. So each, the MMRC versus something else might what am I trying to say? Might produce the data or present it in one way, and it's a little bit different than others. So you kind of have to look at how that data is presented and what the definitions are that they're using as well. So along with that MMRC that I talked about, they got 14 MMRCs together, and they share their information from 2008 to 2017 with the CDC. They found that there were 1,347 deaths to women during or within a year of pregnancy. And pregnancy relatedness determination was made for 1,260, which is 93%. And among those, they determined that 454, or 36%, were determined to be pregnancy related, meaning that during pregnancy or within a year of delivery, and likely related to pregnancy itself. And some of the findings that they found, that they came up with, or the key findings, is that 1 in 3 deaths among women during or within a year of pregnancy were pregnancy related. They occurred during pregnancy, delivery, and up to a year postpartum. The leading causes of death varied by race and ethnicity, and we'll talk more about that. And then they also found that pregnancy-related death was associated with several factors, including some of these things Dr. Nwabuobi mentioned: access to high-quality care, missed or delayed diagnoses, the lack of knowledge among patients and providers about the warning signs, and those are the things that we talked about in our last discussion. You can go back to my Instagram TV and watch that discussion about the urgent maternal warning signs. And I'll digress a bit. That discussion was really good because we kind of differentiated between what might be normal pregnancy versus when to be concerned that it might be pathologic. That's the key. Yes. Because what happens is we can't, as providers, rely on the patient to make that determination.
No.
They're not physicians.
No, they're not.
Right? So they can't say, you know what, doc, this is pathologic. This is not normal pregnancy. They don't know. All they know is they don't feel good.
Yes.
So it's our job to make that differentiation. So if we're not, it could be that you're not doing your job. It could be that we don't know enough.
Yes.
It could be for whatever reason that we're not able to make that differentiation, but it rests on it's our job to figure that out. Would you agree with that? No,
I agree. And, it's very easy in a very busy obstetric practice or OBGYN practice where, I knew as a resident, there was a private practice doc, he was seeing a day, 50 patients. And, people would say things like, oh, but I already know the patients. Yeah. But, if you're kind of moving at that rate, it's hard sometimes to even have patients who will feel comfortable enough to ask you the questions. I actually see it in my current practice where patients will come to MFM, and for some reason, it's like they come and they remember all the things that they could have asked their general OB. But when I looked a little deeper into it, I just found that they just felt more comfortable. Yes. And it's like I created an environment that was more nurturing. And they just felt like, this is probably the right guy to ask this question. And, sometimes you're like, are you talking to your regular OB? Because this sounds like a regular OB question. Nevertheless, they just happen to find that your office, your space is a more comfortable space for them to ask those questions, and you fill in those blank spaces for them. But this is a job for everyone to jump into. Yeah,
I agree. So along with those lines, the MMRC data suggests that a majority of the deaths, 60% or more, could have been prevented by addressing these factors at multiple levels. So the ball is being dropped on multiple levels, essentially. And if someone had just picked up that ball, then it could have been made a difference. So be the person that picks up that ball. Yes. If you're listening to this, whether you're a provider or you're involved in the obstetrical care, or you're the partner, or you're the friend or the family member that's in the room, that can make a difference too. Because I've had some times where, and I'm sure you've been in the situation where the patient, the patient that they do not feel good. There's something not right. but you
Yes.
can't really, and I feel like we're probably the same as far as providers. Patients tell me a lot, but it could
Yes.
be because they just don't feel well.
Mm.
They're just not talking. And
Yes.
it's the person that's sitting next to them that drove them to the hospital that gives you that key piece of information
Yes.
that's been missing,
Yes.
right? That can change the complete course of what's going on with that patient. So I think the patient, the whoever's with them or brings them, is just as important
Absolutely.
in that care. What, have you been in that experience? Had that situation before?
Yeah, I have, and I think it's something that's it's a priceless asset that we actually have having family members with them. And like I said last time, there's been cases where you are not necessarily trying to say to the mom, "Do you feel like you gain more weight on your
Yeah,
face,
yeah,
your arms?" Just because it could be
yeah.
a sensitive issue to a woman in pregnancy. But just looking at their family member and say, "Hey, do you think anything looks different?" And they're like, "Yeah, I just feel like her face is more swollen." Now, in the setting of being concerned for, elevated blood pressures and then having a family member say, yeah, in a very short period of time, she has gained a lot of weight, that could help you piece things together to say, hey, let's go ahead and run those labs. Because then you could now end up with a diagnosis of preeclampsia, which the patient would not necessarily be able to tell you what exactly is happening. So I think this is a whole team effort. And when we say team effort, it's not just the medical team, it's
Yeah.
the community, the family members. I mean, it extends beyond the office and the hospital space. So I absolutely agree.
Absolutely. Okay, and then we'll go over, I'm just going to go over some of those stats from this, the MMRC data from 2008 to 2017. As far as characteristics of pregnancy-related deaths, they found 8.6% Hispanic, 39.2% non-Hispanic Black, and 48.1% non-Hispanic white. As far as the age at death, the most commonly occurred at age 30 to 34, followed by 25 to 29, then 20 to 24, and then 20 to 24, and then lower, greater than 40 was the lowest. That's probably because that group is not having as many babies. And then the lowest was 15 to 19, which makes sense because they're younger and healthier. As far as when these deaths are occurring, the most often it occurs, let's see, during pregnancy, followed by 7 to 42 days postpartum, then 1 to 6 days postpartum. That was pretty much equal to 43 to 360 days postpartum, but it was the least likely to occur on the day of delivery or within that immediate time period. So this is important information because if you remember, a lot of things have been put in place that really focused on that immediate postpartum, delivering immediate postpartum period. A lot of actions were put in place and do this and this, but they found that it didn't really help. But that's because a lot of is happening after that, these
Yes.
pregnancy-related deaths. So then we realized, you know what? We got to extend Medicaid for the first year postpartum.
Yes.
That's really the only thing. I mean, we need access to care in our individuals up to a year postpartum, because as you can see here, they're still vulnerable up to that point, right?
Mm-hmm. And the thing is, it's also interesting because you are looking at, it's almost like bimodal. You have this period when they are carrying the pregnancy. You have the period after the deliver. And then you have the period when they are delivering, right? What's happening in the period when they are delivering? Everyone is there. And
everyone's there.
The nurses are there. The doctor is there. The doulas are there. Everyone is there. But that period when they're at home dealing with housing issue, food issues, health complaints that no one really knows what's going going on with them, and the period after they've had the baby, now all the people who showed up for the baby shower are gone. All the people who showed up for the gender reveal are gone. It's just mom and the baby dealing with it. So no one to really look and say, hey, I feel like you look different or something. So we have so much work to do, before the baby comes, but there's a huge concern and huge ball being dropped after the baby comes. And that, even though you kind of broke these down individually, what I'm picking up is that when you add the percentage of after the baby comes, it's
mostly, it's after the baby is born. That's it. Yeah. All of that together is going to trump even during pregnancy.
Yes, correct.
Yeah, right. Correct. Okay, so let's jump into now some of the different causes, underlying causes of pregnancy-related deaths. And this table, you guys don't have access to the table, but we'll talk about it. And this is broken down by overall underlying causes of pregnancy-related deaths, and then by race and ethnicity. Again, this is from the 14 MMRCs from 2008 to 2017. So Dr. Nwabuobi, just to discuss a little bit, we're going to talk about first cardiovascular conditions. And non-Hispanic Blacks, that is 13.9% compared to non-Hispanic whites, which is 13.4%, which is the leading cause from this MMRC time period, which when I was training, that wasn't the leading cause of death. So it's starting to become the more leading cause. So explain why cardiovascular disease or conditions are becoming the leading cause of death in both non-Hispanic Blacks and white women.
So when we talk about cardiovascular conditions, we are thinking about things like, coronary artery disease, things such as congenital heart disease. Now we know all those young girls who had their congenital heart disease repaired, many years ago. Now they're at reproductive age and they are having babies. So we need to remember that things, conditions such as aneurysm, you could go on, hypertensive disorders. So why is all of a sudden we're seeing a rise? Things are different now. The way I look at it is I feel like American diet has changed. We have more issues with obesity in the world today. At the same time, we are also having just women generally having more comorbidities, such as, diabetes, chronic hypertension, like we mentioned, that ultimately having adverse outcome in their cardiovascular health. And the other thing is that we are also having, there's some kind of a bias that is going on as far as like identifying cardiovascular conditions of women. So typically signs that you'll be looking out for in men might not necessarily be the presentation of women will have. So you have a lot of women that are being missed. And I love the fact that there's a lot of institutions now that are developing cardiovascular problems specifically to women. So all these things added together are suddenly pushing, more cardiovascular conditions and pregnancy that are now causing a lot of harm to moms and babies. So I think that is definitely something that we are starting to pay more attention to.
Yeah, and along the same lines is also cardiomyopathy, which I actually posted on that today about peripartum cardiomyopathy, but cardiomyopathy in general. So talk a little bit about, since we're talking about cardiovascular conditions, cardiomyopathy obviously would go along with that. But those are the two leading underlying causes of pregnancy-related deaths among non-Hispanic Black women. What, in your opinion, is contributing to that?
Based purely on clinical, practice, I think in Black and Hispanic women, a lot of these comorbidities tend to dominate, right? Things that will lead to your cardiomyopathy, the things that will lead to your, coronary artery disease, also things such as, like we say, diabetes, things such as obesity, things such as, hypertensive disorders, and also genetic factor to it. So this, from a clinical standpoint, absolutely, is contributing to it. But also, we also know, other sides of it, which is the sides of, the implicit bias, which we touched upon last time, and also systemic racism, because it's very interesting in the hospital system when, two different group of people complain about the same exact thing and how the response to it, tends to be. We are aware of, very, very successful people like Serena Williams, who, had a history of pulmonary embolism, right? A history of clots. And at the time of following her delivery, she was concerned that I think the same thing is happening again and complained about it. And even with all the, accolades that she has garnered in her lifetime, still she was not heard, okay? Going back to get her. She was not heard, and it took her proving to the physician, who ended up not even ordering a CT scan of, CT angio of the chest, but instead started first with a lower extremity Doppler. And then a clot was seen, and then she was treated. But again, it's multifaceted, but we cannot ignore some of these comorbidities that are underlying in the first place. And then ultimately the society we live in that we definitely all need to work on, on ourselves and look at.
Yeah. And we also have to consider as well is not getting adequate care, either because along the way, which has led to undertreated and underdiagnosed medical conditions in non-Hispanic Black women, because they're not getting equal care and equitable care based on the color of their skin. Then you also have to add on the distrust in the medical system and avoiding going to the doctor, which allows any underlying medical disease process to progress and be unmonitored. So that is contributory as well. So it's multi-layered, but unfortunately it is rooted in racism and it is rooted in bias. And that's something that we have to consider as obstetrical care providers. and understand. I've heard over the years, oh, they weren't compliant, or they weren't, they didn't go to a prenatal visits. We have to consider why. What is the why? What is the why? That why may have started a long time ago when they were mistreated, or not listened to, or not heard.
Yes.
Something else, and it's caused a significant distrust in the medical system.
Yes.
So we have to stop shifting the blame towards the patient and understand how they got to where they're at. And we may not be able to fix it, but we can make it better. And at least there's a level of understanding there. Does that make sense?
It makes sense. And let me just add something to, trying to know the why. And that is what can be, I'm going to try to be as unbiased as possible. Us as healthcare providers, our jobs, we are quite busy at work, right? Like I always tell people, when I leave my house every day and walk into the office, I leave everything, not even in the parking lot, but at home, because I'm coming here knowing that it's time to work and take care of these ones. One thing I got to say is this: there's equality and there's equity, right? You could make things as equal as you want it, right? You could give everyone access to this office today to come and see a maternal fetal medicine doc. But where the issue arises, and this is where we start having issue with compliance, is that if the mom who works at the Amazon, warehouse comes out at 7 p.m., but the maternal fetal medicine office is done at 4:30 p.m., 5 p.m., right? How do they get a chance to come for that visit? If the mom who's working the night shift, and my dad was a nurse's aide for so many years, he just retired last year. If he's working a lot of night shifts, right, how does he get a chance to come and, keep up with the appointments that you are setting up in the morning when he's just coming off of that shift? Or the moms who have to check their blood glucose, but the time when they are waking up in the morning is at 2 p.m. So they really don't have like your true fasting. They're fasting, so there are so many layers to this. The thing is that we get so consumed at work as healthcare providers that sometimes we do not have a chance. Let me not say we don't have a chance, but we don't give ourselves a chance to kind of sit back, take it easy, and kind of try to look at it from a different lens. Because it's easy for us to say they're non-compliant until one, versus trying to sit back and say what's going on at home, where you come. And sometimes we're afraid of finding out what is the real problem. Because once we find out what the real problem is, well, you got to do something about it. So it's tough, but we all have to constantly remind ourselves what this all entails, and that our patients, a lot of them are carrying a lot of load that is just very difficult for them to deal with.
Right. And I get that. Sometimes we know what that question is. It's going to open that Pandora's box, and we try to skirt around this. You just got to ask it. You got to ask it. I mean, sometimes asking that question it will explain so much.
Yes.
And even asking it makes a difference with the patient.
Yes.
That you asked it, and they may not even be expecting you to fix everything.
That's true.
But at least you asked, and now you know. And the diabetics is a great example.
Yes.
And I'm sure you've had that glucose log where you're like, what the heck is going on? Well, I mean, what? And then you find out, like you said, I'm working the night shift, or I'm working 2 shifts.
Yes.
I don't have time to take snacks. I've got to take care of my kids.
Yes.
And that's when you just pull up a chair, you do the best with what they've got, and you work around it and give them tips on how to make it better. So, but if you don't do that, you don't ask, you're not going to know.
You're not going to know.
You're not going to know. Okay, so the second leading cause of death from this MMRC review was hemorrhage. And talk a little bit about hemorrhage. We'll go basically through the top 3 causes. Cardiovascular conditions is number 1. Hemorrhage is number 2. Infection is number 3. What about hemorrhage? What do we need to know about hemorrhage?
Yeah, so with hemorrhage, so when we talk about hemorrhage, we're talking about moms who have a lot of bleeding following delivery. There are certain cases that it can even happen while a mom is pregnant. But there are certain risk factors that us as obstetricians, medically trained, are able to see in a mom and can anticipate a mom who's at risk for, cases like postpartum hemorrhage. In the antepartum setting, now you're talking about things like, does the mom have placenta previa? Is there a creta where the placenta is kind of burying it a little further than it should? Things of this nature. However, if you have moms who clearly have risk factors, you're talking about moms carrying twin pregnancy, moms who had hemorrhage in their last delivery, moms who have labored for a very long time, we can sometimes be able to get things in place in anticipation that if this was to happen, this is what we're going to do next. Now, the unfortunate cases where moms are coming in with heavy bleeding and no one knows that they have a placenta previa, you know, things of that nature. Yes, we do not anticipate, but we still need to follow clinical guidelines that a woman presented at this gestational age with this complaint, that you need to do your due diligence to evaluate them completely. And that includes finding out where is the source of the bleeding. Is it from where the placenta? How long has it been? Et cetera, et cetera. But this is a big killer of women. And also, if you're working in an institution, you know, that might not necessarily be tertiary care, you do not have access to, you know, a lot of blood products, you know, things of this nature that can resuscitate mom. That can also put some strain to management of this condition. But hemorrhage is I mean, everyone understands bleeding. When it is happening, it's not a good thing, especially when it's not, you know, intentionally initiated. So something that we should look out for in pregnancy.
And the other thing is postoperative hemorrhage, especially after a C-section. That can happen where they bleed intra-abdominally. And paying attention to those first 48 hours on the floor, on the postpartum floor after something like a cesarean section is so crucial, so crucial. And I'll, you know, this goes along with the Kira Johnson Act, and I'll tell her story. But that was what happened with her. But, you know, we have to understand that even though we sewed up and it went on the way, it doesn't just end there. We still have a freshly postoperative patient. Everyone has to have their eyes on that patient and act accordingly. Because the thing is that pregnant individuals are designed to lose blood. That's why their blood volume goes up, and that's why they get anemic, because they are designed physiologically by nature to tolerate a lot of blood loss before they start showing signs. So before you have someone showing signs of blood loss, meaning they're tachycardic, they're starting to get pale, their blood pressure starting to drop, their urine output drops off, they could have already lost 2 liters of blood.
That's true.
Easy.
True.
And because their body's designed to do that. But that doesn't mean that just because they're not showing signs that we could just chill and wait. You got to be on it.
Absolutely.
You have to be on it. And that's important to understand. And that's why one of the maternal levels of care, I don't know if you guys have that in Ohio yet, but in the state of Texas we do, where the labor and delivery units are getting designated with different maternal levels of care. And, you know, the access and what, you know, the system that's in place for notifying, you know, abnormal vital signs and things like that is all contributory to what level of care you get, which needs to be done across the nation, and hopefully it will be.
Across the nation, absolutely.
Yeah. And then we'll talk a little bit about infection. Talk a little bit about infection and why does that contribute to pregnancy-related deaths?
Yes. So infection, I mean, just the word alone, you know, it's not a good thing. So in pregnancy, it's very interesting because infection comes in different form, right? Like you could have infection that has absolutely nothing to do with the pregnancy itself. You just happen to have a, you know, maybe some kind of cellulitis, infection of your skin. But then you have things such as a urinary tract infection that we know pregnancy by itself is a risk factor for. And then you could even take it further into things like, you know, intra-amniotic infection, where now the infection is actually inside of the uterus. And the way to address that is actually to, you know, deliver mom. But then in conditions where an infection, you know, worsens, right? And also, by the way, just to include infections, let's not forget about things like COVID. Here, talking about things like pneumonia, flu, I mean, we'll go on and on. But the main point is to be able to identify that there is an ongoing infection as early as possible. Because any untreated infection can always worsen to a condition that we do not like to talk about, which is sepsis. And in a situation like sepsis, a mom can die, a baby can die. Sepsis is one of those very important conditions that any physician, whether it be an obstetrician or non-obstetrician, definitely wants to understand the management, because it can take a life instantly if you do not initiate the appropriate care at the appropriate time. So, you know, infection is one of those things that we definitely like to keep an eye on, because it can take lives. I can think of different moms. I will never forget a mom as a resident who, you know, got so sick from having the flu. She was intubated for a very long period of time. We almost lost her. But, you know, it's just something people, you know, can think about, oh, it's just the flu, and how much, I mean, it almost, took this young girl's life. So, again, it's very important. It comes from different angles. Different organs can be involved, but immediate action is very important to treat it so it doesn't worsen.
Right. And then some of the other causes on this list are going to be embolism, which is a blood clot, thromboembolism in the lungs, namely, but they could start with blood clots in lower extremities, like with Serena Williams.
Yes.
Preeclampsia, eclampsia, and then mental health disorders. And mental health disorders is the leading underlying cause of death amongst non-Hispanic white women, is mental health conditions and the associated comorbidities with that. So, it is going to vary by race and ethnicity. It's going to vary by age somewhat, but recognizing what the main contributors are and acting promptly. And again, remember understanding what the physiology of pregnancy is, because even with infection, someone can be very, very sick. And I'm the 16-year-old with pyelonephritis that's
Yes.
septic that walks in, her only complaint is that it burns when she urinates. And the next thing you know, she's in the ICU.
ICU, intubated.
And, we have to read between the lines and understand that the pregnant body is designed to tolerate a lot before they actually get sick. We just don't want to wait that long. And so what does that mean? We have to listen and we have to hear her and talk to her and understand that even though she may not look or they may not look sick.
Yes.
Some of the sickest patients I've had actually didn't look that sick.
Yep.
Right. And we have to understand that and read between the lines. It's very important. Okay, so we'll move along to the pregnancy mortality surveillance system. That it's called PMSS. That defines a pregnancy-related death as the death of a woman or pregnant person within a first 1 year at the end of the pregnancy, regardless of the outcome, duration, or the site of pregnancy, from any cause related to or aggravated by the pregnancy or its management. The PMSS uses the pregnancy-related mortality ratio, which is the PRMR, and this is an estimate of the number of pregnancy-related deaths for every 100,000 live births. So since the PMSS was implemented, the number of reported pregnancy-related deaths in the United States increased from 7.2 deaths per 100,000 live births to in 1987 to 17.3 deaths per 100 live births in 2017. So what might account for that? It seems like a drastic increase, 7.3 to 17. 7.2 to 17.3. What might account for that huge increase over that span of time?
Yeah. So I think one, we cannot ignore the fact that once you decide to start collecting data, you're gonna start picking up more things. Yeah. So I think we've done a good job with just the surveillance and paying attention to the statistics. I think also the other thing is that things have changed as far as like the comorbidities women are carrying now. Is a lot more than I would imagine 1987. And also, I'm thinking the fact that we have more women of advanced maternal age, having babies now, that also comes with certain complications that we do discuss with our patients. So I think some of these factors, interesting enough, something that might not be talked about enough, but I think we brought it up in different points in this conversation, is the fact that there is so much wealth gap that we have noticed in the U.S. Actually, I think it's from like between the 1970s to now. The wealth distribution, I mean, it's so unequal that we have not seen anything like this in over 30-something years. So that's actually very unfortunate for a very wealthy country, with all this, all the resources, both human and mineral. But that fact, poverty by itself, is something that can contribute to adverse medical, pregnancy, name it, whatever kind of outcome. When people are living in poverty, when people do not have access to a safe place to live, good food to eat, good and nutritious food to eat, just generally good housing, good communities to be around, that right there can affect. There's been studies where they have looked geographically where you live, your zip code of where you live, and your pregnancy outcomes. And we could tell those zip codes are definitely not Beverly Hills zip codes. They are definitely, the very poor places that, a lot of us do not want to live in. But obviously, those ultimately trickle down to the babies and the outcomes of the moms. I mean, go on and on. So it's interesting, but I think it's another multifaceted, but I think definitely these factors I've pointed out have contributed in that increase.
Right. And then the CDC, based on analysis of this national data on the pregnancy-related mortality from 2007 to 2016, here's a few of their stats. They found that non-Hispanic Black and non-Hispanic American Indian, Alaska Native women experienced higher PRMRs, or the pregnancy-related mortality ratios, than all other racial and ethnic populations. What was the next stat? And this was 3.2 and 2.3 times higher than the PRMR for white women. And as the gap widened among older age groups. For women over age 30, the PRMR for Black and Alaska or American Indian and Alaska Native women was 4 to 5 times higher than it was for white women. This is another one. You mentioned this our last conversation. The PRMR for Black women with at least a college degree was 5.2 times higher than that of their white counterparts. So this whole thing with education means you're going to get better care. Does that not apply to Black women?
Yeah, so it applies to every other person but Black women, and very unfortunate, because for a Black man like myself who has married to a Black woman and has 3 Black daughters, it's concerning, because obviously I'm doing my best every day. My wife and I are trying to give them access to good education, give them access to opportunities we did not have, but also understanding in the back of your mind that it is very possible that some of these things that you are setting them up with might not necessarily be protective.
It may not be enough.
It might not be enough. And it's very unfortunate. And I've been asked, why do you think that is so? I think what tends to happen sometimes is that when you have a very educated Black woman, right? What comes with education is that you are now able to advocate for yourself better. And then when you advocate for yourself more, then you are looked at as the man and angry.
Yeah. And it's
right?
threatening. It's threatening.
And threatening. And when people sometimes feel threatened, they withdraw. And when they withdraw, they also take the care away, and then they become dismissive. So I think that can sometimes explain what's happening with, high class, well-educated Black women also having 5 times. I mean, that number is mind blowing.
It's mind blowing. Yeah, it's mind blowing. I mean, we're not laughing about this. It's just when you see it on paper and you see these stats, you cannot deny that.
No.
And it makes no sense.
No.
So I think what Dr. Nwabuobi just said is exactly right. An educated Black woman who can advocate for herself is seen as a threat, rather than an educated woman.
Yes. It's true.
Whereas if I went in the exact same education, I wouldn't be perceived that way because I'm a white woman. So does that mean that I should get better care because I'm less threatening? And it's just not right. There's no way you can look at this and explain it away or justify it.
Justify it. No.
Right. Okay. Even in the states with the lowest PRMR, and again, Dr. Nwabuobi talked about, you look at geographical distributions. The PRMR for Black women was still 3 times as high as the PRMR for white women, even in the states with the lowest PRMRs. Let's see, cardiomyopathy, thrombotic pulmonary embolism, hypertensive disorders of pregnancy contributed more to pregnancy-related deaths among Black women than white women. You have hemorrhage and hypertensive disorders of pregnancy contributed more to pregnancy-related deaths among American Indian, Alaska Native women than white women. And the disparities have not significantly changed. So what are we going to do about that? Or what can we do? What should we be doing?
Yeah, I think, it starts first with creating an awareness. 2020, and excuse me if I said this at the last IG Live we had, which everyone go check it out if you've not. But, 2020 brought a lot of sad things to the world. One of them being the unfortunate loss of Mr. George Floyd. Part of the blessing he left with us was the increase in awareness of some of the difficult time a group of people in this country have been going through. So increasing awareness to some of the social injustice. I think the same energy was also transferred towards health disparities and health injustice that has been going on as well. I think once people started hearing about it, they're like, oh my God, I did not know this was happening. I did not know this is the case. That right there started the conversation. And what I think we're not having enough of is the conversation. And I think for certain reasons, it's actually become not cool anymore to have the conversations. Actually, people encourage you to just go do your job and go home, okay? And do not try to talk these things. But if we do not have these conversations, it is very hard for us to educate each other about what's going on in our little, communities. So I think past the education, the next thing would also be to create protocols, create initiatives that are actually focused and targeted towards addressing these conditions. There's a lot of talking about health disparities. What I'm not seeing a lot of is actually true programs targeted to it. Like people, I see hospital systems again, and nothing against hospital systems, but sometimes I get annoyed by the administrative part of it.
Yeah.
But I see a lot of hospital systems push about they're trying to increase access to care and stuff like that. But when you look at all the new hospitals that are being built, when you look at all the new urgent care centers that are being built, they're in the suburbs. Okay.
This is the other thing. There was a recent study, some data out, and you kind of these polls and these things, the way they look at hospitals, but there was something to be said. Some of the best hospitals were not representative of what the neighborhood around them was.
That's
so the population was not the same. So that's a problem. If you look at the population of hospital systems taken care of is not representative of the people that live around there at all. What's going on?
At all. And that continues to perpetuate the trust issues that has been in the system, right? Like why in 2021 is there a whole campaign targeting minority population? Is not because of just, everyone keeps mentioning Tuskegee experiments and stuff like that. No, it's because of the things that continued to happen even after that, right? Like you could look back and say, oh, but that was back then. Yeah, the issue is that it continued happening as recent as last year. So people tend to become skeptical when they understand the fact that they are walking into a place that does not look like them or they do not feel represents.
They're already walking in at a disadvantage just based on how they look.
Yes.
How they look. And and we talked about this in the last conversation, watch it, about equity versus equal versus equitable care. We have to address the equity, make it more equitable.
Yes.
And we have to address, and like you said, you can have all these wonderful programs, but if the individuals that make up the programs don't believe it and understand there's a problem, it does not matter. We have to focus on the individual and focus on the implicit bias. We have to focus on systemic racism and fix that so that our people of color feel comfortable even coming to the hospital.
Yes.
That's something that has to be done to at a baseline level.
And I will just say this just because, your platform is amazing. And again, always thank you for giving me this opportunity. I find myself a lot of times going through all my whole training. I always find myself a lot of times being either the only Black person or just one of few. And it's the higher I went in my training, the worse it actually became. And it's always been my goal throughout the process to try to advocate diversifying whatever environment I find myself. And, sometimes I kind of get the feel of people feeling uncomfortable when I say, you consider this other person. I'm not saying those things because I am trying to fill a quota. I'm saying those things because I feel like that person is well qualified and I feel like they can bring something to this place. I work in a place where I take care of a lot of Muslim women in our population, a lot of refugees from Southeast Asia, African countries. And, but the people I work with, and I love everyone I work with, I feel blessed having these people as part of my team. But at the same time, when I look around and I see that, it's me, one other person, it's just not representative. And there are conversations I know that I'm able to walk into a room and have with, someone that looks like me, not necessarily because I'm saying something different from my partner.
It's a level of understanding.
There's a level of understanding. There's a little twist I'll put to it that will just make them feel like, oh, thank you very much for, explaining it better to me. So we can be a little conscious in making some of these things. And that has absolutely nothing to do with someone getting access to something they do not deserve. No. We've gone past that. So
right. I agree. Yeah. So let's talk a little bit about, we have about 10 minutes here. What advice can you give to a pregnant individual, postpartum individual, on how to advocate for themselves? What would you tell them about advocating for themselves, and also friends and family members? What can they do to be advocates for their loved one?
Yes. So, starting with the patient themselves, I think it's always important when, you as the patient, you come to the appointments prepared, right? Like,
Mm-hmm.
let's say during the week, you read up something on social media, which, I see a lot of your posts going against people who are constantly sharing misinformation.
Mm-hmm.
And I just have to say this, social media has been amazing as far as like reaching out to patients
Yeah.
that's my passion. But there's so much misinformation out there that blows my mind when I
Yeah.
read something. I'm like,
Mm-hmm.
oh my God. And this person has hundreds of thousands of
Yeah.
followers. People
Mm-hmm.
actually believe this person. So, as much as whoever is tuning in or who's gonna watch this later, if you're a patient, you read up on something, just write it down. Bring it to the next appointment, talk with your OB and say, hey doc, I read up on this, I saw this person give this presentation, what do you think about it? Don't just take people's word for it. I mean, like, I
Mm-hmm.
see random degrees I've never heard about before that people put next to their name, and and they sell it so well that people believe and go with what they're saying. So come as a patient very prepared, and engage your provider, whoever they are, your midwife, your doctor,
Yeah.
name it, whatever they are, engage them. That right there will let them know this is not someone that you could just throw around or mess around with.
Yeah. Ask why and ask questions.
Absolutely. Once you do that, we take notice and we always come ready because we know. You also posted something the other day that I thought was funny because I just had this conversation about why are people being checked?
Mm-hmm.
Why are you being ask? Why are you
Mm-hmm.
checking me? There's
Yep.
there's nothing bad about, oh, so what am I being examined for? Like, no reason. Have
Mm-hmm.
to justify. As far as family members are concerned, I think it's always a thing when you see a patient coming, to appointments with a family member or something like that. Some of us are busy. I'm guilty of that. When I was a resident, my wife was pregnant. There are a lot of appointments I didn't make, but it's understandable. But it's a different situation. People knew who I was. But if you have a family member who could come with you to appointments, because there are questions you might not remember that they will remember, and again, that just puts whoever is taking care of you in check to say, hey, this person is not alone. They got a whole team. They got a whole community with them that is going to
Mm-hmm.
look out for them. So, but I think the advocacy thing, advocating for yourself goes beyond just the patient. It goes with the family members, their friends, and thank God for FaceTime and things of this nature.
Yes.
They do not necessarily have to be there anymore. You can
Yes.
actually get them connected via things like FaceTime or
Mm-hmm.
some kind of video chat to be a part of your care.
Yes. And whenever we go into a room as a provider, ask who the people are in the room with them, because if they're in the room, they're more than likely there because the patient wants them there.
Yes.
Involve them. I don't always ask the patient, do you have any questions? I ask whoever's in the room, do you have any questions? Do you understand? I make sure the entire room knows. And I'll say, if they don't have a support, if there's somebody that you want to hear me to talk to about this, have them call. We will discuss it.
I do that
They
too.
know that, because sometimes they're not there, or the person that the father of the baby or the mom, whoever that main support person's not there, and they need to have that conversation and they weren't there at that time. Offer to talk to them. And they take me up on that a lot.
Mm-hmm.
But as long as they know that you're willing to do that, that means a lot, and it goes a long way. Because the more people that know the plan, know what's going on, the better.
Yes.
Especially when that patient is going home, what to look out for, all of that. You have to educate the entire support system every chance you get as a provider. That can be done. So I just want everyone that's listening to this to know that as a physician, if any physician takes it personally that you're asking why, that's their problem. It's not yours.
Not yours.
It's not your problem. You have the right to ask why, and you have the right to ask for an explanation, and what the plan is. You can ask. It's your body. If it wasn't for you, we wouldn't have a job.
That's true.
Right? I mean, if it wasn't for you, we wouldn't have trained, first of all. We wouldn't have gotten our training. We wouldn't be where we're at if we didn't have patients. If we're being a-holes to our patients, then we don't deserve to have patients. If you can't take a minute to talk to them, then we don't. I mean, what was it? The customer's always right. Now, it's a little bit different, but I mean, it's kind of the same. It applies. If they want to ask questions, we need to sit down and answer them. So you have the right to do that. Okay, you have the right. So I just want to close this conversation by talking about the Kira Johnson Act. This is there's an account that's called 4Kira4Moms.com. So basically, Kira Johnson went to Cedars-Sinai on 4/12/2016. She delivered her baby boy by cesarean. At the bedside, her husband, Charles Johnson, noticed blood in her catheter. That was reported. A CT scan was ordered stat at 4 p.m. An ultrasound was done at 6 p.m. because a CT scan hadn't been done yet. It showed fluid in the abdomen, which was likely blood. Her hemoglobin was dropping. Her blood count was dropping. She starts to lose color. Her husband at 8 p.m. Is begging for help. Still no CT scan. She starts getting a blood transfusion at 9 p.m. He was told that his wife was not a priority. That's why she had not gotten a CT scan yet. After midnight, she went to the OR. So 8+ hours later, while she's being rolled back to the OR, Kira told her husband she was scared. He never saw her again. She had 3.5 liters of blood in her abdomen. As soon as they opened her abdomen, she coded immediately and left behind her newborn and her 18-month-old son. So her husband, Charles Johnson, and this For Kira for Mom on Instagram and the website, they do an excellent job at educating on these very topics and about how to advocate for yourself. The Kira Johnson Act is now, where is it? I had that. It is on 3/25 of 2021. It was introduced in the Senate, where it's at right now. Basically, this is some of the things that it asks for. Fund grant programs to reduce bias, racism, and discrimination trainings for all employees in maternity care settings. And just as a side note, Kira Johnson was a very, very highly educated young lady, individual, very, very educated. And I don't have time to go into all of that, but you could go to the website and the Instagram account and learn all about her. Provide funding for community-based organizations to prevent maternal mortality and severe morbidity among Black women. Establish respectful maternity care compliance offices within hospitals to provide mechanisms for pregnant and postpartum patients to report instances of disrespect, evidence of racial, ethnic, or other types of bias, and promote accountability. And direct the national academies to study issues related to these training programs and the impact of the compliance offices. So to support this, and I actually already signed it myself, you go to forkira4moms.com, and there's a link there. You can send a letter to your local senators and representatives. Please do that. I'll put the link actually in my Instagram on the caption. I'll share it in my stories as well. But that's one thing you can do to help advocate for individuals. This act is excellent. I hope that it's going to go through. I don't see why it will not, but what it's wanting to do is a lot of these things that we just discussed. But it has to start somewhere, and a lot of these things, if not already being done, which they should, I wish, just go read her story and learn about her. What happened to her should not have happened. First of all, I just want to digress a little bit. You don't need a CT scan to diagnose intra-abdominal hemorrhage. You need a finger and a patient. That's the first thing that I wanted to say. I do applaud Charles Johnson, her husband, and her family that has really supported that and is doing this. This is amazing. Dr. Nwabuobi, any parting remarks here?
Again, thanks as always to all the people listening. I just want to say that we are here for you guys. We will continue to learn from you, and it doesn't stop in residency or fellowship. And please let us know. Not only are we saying hear her, but we're also saying tell us. Okay.
Yes. Yeah.
Let us know. And we want this whole process of pregnancy care to be a partnership. And with that said, I am really hoping for the Kira Johnson Act to pass and for some change to come to the system.
Right. And I'll put that in there and share it on yours too, so that we can get some signatures for this and some letters sent to the Senate. So, all right. Thank you so much. Have a great rest of your week. And I'm sure we'll do a part 3.
We're going to do it again.
Okay. Thank you so much.
Thank you. Have a good one.
Bye-bye.
Bye-bye.